from Bayer company. There is a lecture. Anybody ready with the lecture here from Bayer company? And the presentation is done? No. So we resume our scientific activity. Dr. Brazan Rao will make a lecture about the paradigm shift to the management of diabetic macular edema. Dr. Rao, please.
Sorry for the interruption.
Good afternoon, friends. Let me introduce myself. I'm Dr. Rao. I'm a vitreoretinal surgeon working in Dubai. I'll be talking to you on paradigm shift in the management of diabetic macular edema. As we are all aware, the prevalence of diabetes in UAE is pretty high. The recent International Diabetes Federation's report stated that the prevalence of diabetes in UAE is about 10.7%. If you look at the curve on the right side, you'll see that this is the prevalence of diabetes in the world. And the graph on the red depicts the prevalence of diabetes in UAE. So if you compare the world and the present generation in UAE, it's pretty high. It's estimated that in the year 2030, we are going to have about close to 600 million patients who have diabetes. So this is a pretty high number, and in future, we're probably going to have a major epidemic of diabetes in the entire world. So what is the prevalence of diabetic macular edema? If you remember our undergraduate days, all of us were taught that the prevalence is related to the duration. If you look at the duration and the prevalence, about 1/3 of the patients in type 1 diabetes will get diabetic macular edema at the end of about 20 years. A similar number in the patients who have type 2 DM as well. Does diabetic macular edema have an effect on the quality of vision? Yes, it does. If diabetic macular edema is left untreated, about 50% of the patients will lose 2 lines of vision within the next 2 years. It also affects the quality of our vision in terms of our daily routine activities, like reading, driving, reading, other of our daily activities. So how has our treatment of diabetic macular edema evolved? In 1999, we had the landmark ETDRS study, which defined the role of laser in patients having diabetic macular edema. In 1999, we started using triamcinolone, which was an off-label indication for treatment. Later on, we had bevacizumab, which is again an off-label indication. Then in 2012, we had Lucentis or ranibizumab, which was FDA approved for the use of diabetic macular edema. And recently, we had Ozurdex or dexamethasone implant, which was approved for the use in diabetic macular edema. So what is new in 2014? We definitely know the role of VEGF in patients with diabetic macular edema. This is a landmark paper by Quindong Kuan. We published and we clearly showed the role of vascular endothelial growth factor being the critical stimulator for patients with macular edema. So we have a new molecule in the market, a new drug, which is known as aflibercept. So what is aflibercept? Aflibercept is a soluble fusion protein. It is biologically engineered for human use and to be used ophthalmically. It has specific properties of different naturally occurring component molecules. If you look at the diagram here, you'll see that this is a VEGF F1 receptor, and this is the VEGF F2 receptor. We have specific sites on these receptors which have been pulled out to form a single arm of the molecule. So we have two identical arms on either side. And then what has happened is these two arms are then fused with a human FC portion of immunoglobulin IG. The principle behind this is these two portions of the receptors have been taken because of the high affinity for VEGF-A and for PLGF. Each arm, how does aflibercept work then? Each arm of the VEGF trap I binds to the binding sites on either pole of the active VEGF. So this is the VEGF molecule. On either side, there's a binding by the receptor. And then this fusion is extremely stable. It binds in the ratio of 1:1. And because of its unique binding capacity, it has a very high affinity, almost 100 times greater binding capacity to VEGF-A than either bevacizumab and ranibizumab. These are the other anti-VEGF medications which we use. So what is the role of aflibercept for diabetic macular edema? In the next few minutes, I'm going to discuss with you an interesting study. This study is known as, there are two studies, there are two mirror studies, which are known as VISTA and VIVID. VISTA is a mirror study which was conducted in the US with about 54 centers, and VIVID is a similar study which was conducted in Japan, Europe, and Australia. So what is the study design? It's a randomized, multi-centered, double-masked trial of patients who have clinically significant diabetic macular edema with center involvement, with ETDRS best corrected visual acuity of 2040 to 2320. There are a huge number of patients in both the, almost close to about 850 patients were recruited in the trial. Patients were randomized into 3 arms. Intravitreal aflibercept 2 milligram every 4 weeks. This is the first group. The second group was intravitreal aflibercept 2 milligram every 8 weeks. And the last was a laser arm. So the importance of this study is this is the only study as compared to the previous studies which compared anti-VEGF blockade with a laser arm. These patients were followed up for a period of 52 weeks and even extended to 100 weeks. And the primary endpoint was to look at the mean change in best corrected visual acuity of these patients. The secondary endpoints were to look at structural changes, changes in the OCT and the changes in the diabetic retinopathy severity scale, whether the patients had mild, moderate, or severe, depending on those. The treatment has been continued for a period of 3 years. These are the baseline demographics. Very complicated slide, but just to remember, these are the patients who were recruited in VIVID trial, done outside US. This is the trial done in US. If you look at the arms, the age, the gender, the sex, the HbA1c levels, and the duration of diabetes between the two groups are almost symmetrical. What is the treatment schedule? So we had 3 arms, as I already told you. In the first group, where 2 milligram of aflibercept was given every 4 weeks, these patients were given injections at 4-weekly interval right up to 148 weeks. And they also had sham laser treatment just as a cover-up. The next group is 2 milligrams of aflibercept given every 8 weeks. It's important to note that in this group, the first follow-ups had 5 injections, which were mandatory injections with that 4-weekly interval, and subsequently they had injections at 8 weeks. They also had sham laser as a cover-up. If you look at the laser arm, which is the arm where the patients had laser in the beginning, and subsequent laser was decided on pre-specified criteria. And these patients were given sham injections. So we're basically comparing patients who were treated with aflibercept versus laser. What is the patient disposition? In any study, you want to know how many patients have completed the study, because that adds to the value of the study. If you look at this study, almost 90% of the patients in both the VIVID and as well as the VISTA covered a follow-up of 52 weeks, and close to 80% followed up for a period of 100 weeks, which signifies that the significant number of patients had completed the study. What are the baseline characteristics of these patients? Which of the patients were recruited? An important factor for us to remember is, in VIVID, almost about only 10% of the patients were previously treated with anti-VEGF medications like pegaptinib or ranibizumab or bevacizumab, whereas almost 42% of the patients in the VISTA were already treated with the previous generation of anti-VEGF medications. If you look at the diabetic retinopathy severity scale between the two eyes, between the two groups, they were symmetrical as well. Any medication, you would want to look at its efficacy and safety. In terms of efficacy, you want to look at structural and anatomical outcomes. So when you talk of structure, you talk of the OCT values and what is the diabetic retinopathy severity scale. If you want to look at the vision, then you want to look at the mean change in the best corrected visual acuity, and you also want to see how many patients have gained vision, more than 2 lines or 3 lines. So let's look at the efficacy of this medication. So this is the result at 52 weeks. If you look at the graph, I just want you to concentrate on only 2 lines over here. The light purple, which basically indicates the laser arm, and the yellow one, which is the 2 milligram dose given every 8 weeks. If you look at the yellow arm, the yellow lines, basically it shows there is a significant improvement in vision, almost 10 lines, both in the Vivid and Vista at 52 weeks. But if you continue the study to 100 weeks, you see this improvement is not only rapid, significant, but it is sustained over a period of 100 weeks. This is as compared to the laser arm, where the patients didn't have much significant improvement on vision. If you look at the patients who had gained vision in terms of lines, almost 1/3 of the patient, again concentrate on the yellow and the purple, almost 1/3 of these patients had more than 3-line gain vision at the end of 100 weeks as compared to the laser arm. Similarly, you had patients in both the Vista and the Vivid doing similar results. So what is the proportion of patients who lost vision? If you look at this, you will find out the more number of patients in the laser arm compared to the aflibercept arm had more loss of vision, both in terms of the 10 letter as well as the 15 letters. After having studied the visual outcomes, we want to study the anatomical outcomes. So we do regularly OCTs on these patients. And if you look at the graph here, you will find that as compared to the laser arm, the arm which is treated being aflibercept had a significant reduction, and the p-values are pretty significant at 100 weeks. You will also realize one characteristic feature. Most of these patients have a sawtooth appearance on the graph, basically indicating that when the injection was not given, these patients have a mild increase in the OCT values. But this OCT reduction, increase in the thickness, is not significant. It was calculated that it ranges from about 10 to 20 microns, which is not a significant value. This is the first point. The second point is, despite there being an increase in the OCT thickness, it did not translate into vision gain changes. So the patients maintained the vision despite having a slightly thicker OCT value. The other point is to look at the diabetic retinopathy severity scale. Aflibercept, we know, works at the macular level, but what happens in the periphery, the peripheral part of the retinopathy? When patients were treated, almost 1/3 of these patients, both in the Vivid and the Vista, had improvement in their diabetic retinopathy scales. That means they dropped, the severity of the diabetic retinopathy dropped when they were being treated with aflibercept. So probably they got from severe to mild or possibly better. The next thing we look at about a drug is how safe the drug is. So in terms of safety, we know most of our diabetic patients have comorbidities. They have hypertension, they have nephropathies, so their risks of getting systemic issues are very high. If you look at the local and the ocular side effects, they are not very significant as compared to the laser arm and the aflibercept arm. So we didn't have any major safety signals associated with aflibercept as in terms of the ocular and the systemic issues. Since aflibercept is an anti-VEGF medication, one of the important points we need to know is what is the risk of stroke. Again, this slide depicts that there's no increased risk of arterial thromboembolic events when aflibercept was used. Another point is risk of deaths, because these patients, as I told you, have comorbidities. There are no safety signals related to death. This is in Vivid trial, and this is the results in the Vista trial. There were no safety signals related to the death. So the conclusion of the study is both Vivid and Vista showed a significant improvement in vision. So intravitreal aflibercept continued to demonstrate superiority in visual endpoints over laser at 100 weeks, which with similar efficacy both in the 2 arms, that is 2 milligram every 4 weeks and 2 milligram every 8 weeks. The best corrected visual acuity gains from baseline were substantial with both the regimen through week 100 as compared to the laser arm. And we all have seen in the previous slides that it's well tolerated and does not have any safety issues. Let me share my experience with aflibercept. Aflibercept it's already FDA approved for the use in diabetic macular edema, center involving diabetic macular edema, and it's been marketed in the UAE for the last 6 months. I'll quickly go over my cases. This is case 1, a 63-year-old gentleman who presented with reduced vision in one eye. He's a type 2 diabetic with high HbA1c and undergone pan-retinal photocoagulation as well. In the month of June, he had a visual acuity of 0.4, and this is his OCT. Now, if you look carefully, this patient has thickening in the central part of the retina. We look at the central subfield thickening level, which is again increased. This is the high-definition OCT, which shows a clear cyst in the foveal area. Classically, we treat these patients with ranibizumab, so the patient had the first injection of ranibizumab in the month of June. He followed in the month of July. Visual acuity is 0.4 again, but if you look carefully, the central subfoveal thickness is increased. We continued giving him ranibizumab. There's a second dose of injection given in the month of July. He comes in the month of August. Unfortunately, his vision is dropped by 1 line. If you look at the thickness before and now, red basically indicates it's bad. So you look at the red quadrant here, it's pretty significant here. White is worse than red. And if you look at the thickening here, it's gotten from 391 to 474. At this point of time, we gave him the option of using aflibercept, which is a new molecule. The patient decided to take it. He took the first injection on 31st of August, and this is his result. Visual acuity improved to 0.9, with a significant reduction from almost 400 to about 329. Patient was very happy. We decided to continue with the second dose, so he had the second dose in the month of October. This is my next patient, a 52-year-old gentleman. He's one-eyed. He lost his vision in the other eye because of a non-arthritic anterior ischemic optic neuropathy 5 years back. His HbA1c is 8.2. This is his good eye with a vision of 0.7. Now he comes to me saying that I cannot read. I cannot do my daily routine activities. He's an accountant, so he can't see numbers. He finds it difficult to work. So this is what I was saying. Diabetic macular edema affects the daily living work of those patients. So with a vision of 0.7, this is the angio. You look at his OCTs, he has thickening there. We decided to treat him with ranibizumab. So he takes the first dose of ranibizumab, comes back to us a month later, vision is improved to 0.8, but he's still not happy, he's still not able to read. Look at the OCT have become more thicker. We decide to continue with ranibizumab because sometimes you have patients who require multiple injections before which the swelling starts reducing. So give him the second dose of ranibizumab. He comes back a month later, vision is still 0.8. The OCT still shows a thickening here. Decide to give him the third injection. Similar result, vision is 0.3, 0.8. He has had the fourth injection of ranibizumab as well. So normally when we treat patients with ranibizumab, we are trying to look at visual stability. If the patient has at three follow-ups, he has stable vision, then you generally stop giving ranibizumab. Because according to the literature, these patients probably don't require any further injection. But look at his case. He was 0.7, he's come down to 0.8, still cannot do his work. At this point of time, we decided to give him aflibercept. He's had the first dose of aflibercept, and lo and behold, vision improves to 1, and you can see the reduction in the thickening. Right from almost 400, he goes to 315. Patient is pretty happy, continues to undergo aflibercept injections. So what does this tell us? We had 2 patients who were previously treated with ranibizumab, and if you remember in the first few slides, I had told you in the VISTA trial, there are about 42% of the patients who were treated in the past with anti-VEGF medications. They were also recruited in the study. And it was found that when they had prior anti-VEGF treatment versus patients who did not have any anti-VEGF treatment, if you look at the responses, they are almost similar. They look almost symmetrical. So irrespective of whether the patient has had treatment in the past with pegaptinib or ranibizumab or bevacizumab, and the patient still has diabetic macular edema, aflibercept does work in these patients. My last case is a treatment-naive patient, a 52-year-old lady who presented with reduced vision in both the eyes. She's a type 2 diabetic for 13 years. And these are OCT, these are fundus images. 0.4 vision, you look at the angiogram, the fovea is well perfused, there's no ischemia, gross leakage on the angio. She has both intraretinal as well as a little bit of subretinal fluid, gross thickening almost 613 microns in thickness. Takes the first dose of aflibercept, comes back, significant reduction from 618 to 369. You can actually see the flattening, almost the flattening and the reformation of the contour of the fovea on the OCT. She takes the second injection and the vision is now gone to 0.9. She also had the injection of aflibercept again. So from 618, her central foveal thickness and as well as the vision have significantly improved. So in this talk, we just saw a few points. We found that aflibercept 2 milligram, which is given every 2 months, unlike the previous generation of anti-VEGF medications, achieved significant, rapid, and durable visual improvement at 52 weeks. The mean gain of 2 lines, which is almost 10 letters, at week 52 was maintained till week 100. And up to 1/3 of the patients achieved 3 lines of gain at week 100. And more than 1/3 of these patients had 2-step improvement in their diabetic retinopathy severity scale. So aflibercept achieves rapid and durable reduction in the central retinal thickness on the OCT, which is sustained up to a period of week 100. It is predictable because you know how often you have to give the treatment, yet it is flexible. You can be proactive. You can decide when and how to treat your patients, and we also found that there are no safety concerns. I want to finish my talk with the last 2 slides. What is the dosing regimen for aflibercept? Now, this is the recommendation. You give these patients monthly injections of aflibercept at every month for 5 times. That is a 4-weekly interval. Once you've done that, you extend the duration. So the patient does not need to come to you for follow-up at 6 months. He comes directly at 7th month and takes another injection of aflibercept. Similarly, this continues till the end of 12 months. So the patient has had almost 8 injections as compared to almost 12 injections as required before. Once the patient has completed 12 months, then you decide. You follow up the patient, you extend the duration. Instead of seeing the patient at 8 weeks, you ask the patient to come back at 10 weeks. Now, when you see the patient at 10 weeks, either 2 things will happen. The patient's macula will be dry, his vision is good. In that situation, you would want to extend it. You give the injection, and then you extend the duration of follow-up. This treatment protocol is known as treat and extend. So once you make it 12 weeks, you continue injecting, and then you continue seeing the patient every 3 months. The advantage being, this patient does not require monthly monitoring, does not require monthly injections. So it reduces the burden on the patient, it reduces the number of injections the patient needs to take, it reduces the burden on the doctor as well. If you have more number of patients following up with you, the number of patients whom you are going to treat is going to be lesser. Because these patients will just come for follow-up more and more. You may not have fresh patients who come to you. Plus, it adds to the burden for the healthcare system. Taking more injections is going to incur more cost for the insurance. What happens when the patient comes at 10 weeks? At 10 weeks, if the patient does not have improvement in vision or there's a little fluid recurring, you then reduce it. So instead of 12 weeks, you come down to 10 weeks, and then you continue at 10-week interval. So this is a flexible dosing regimen. The first year is a fixed dosing regimen, and subsequently it becomes flexible. Thank you very much. Any questions? Yeah, Dr. Eduardo.
We have been the first center to start to use it, and we use it quite often. I noticed this, that can be a relative primary use or indication for using that. In the first 2 cases, you have shown us a reduction of the vision significantly for a single a single cyst generated by edema. In this case, in my experience, I know that the Lucentis, ranibizumab, has no much effect. Don't know for what kind of reason, but for limited internal edema that show us in a cystic way, the ranibizumab has not great effort. Instead, the idea, as you show very nicely in your picture, is makes solve the problem. So in my paradigm of treatment, when I see a case like you show in the picture with localized edema, very central, with few cysts, I start immediately with the Eylea because I know that ranibizumab has no chance to treat. When you have instead much thicker edema or even subretinal fluid, much more compromised picture, yes, both the pharmaceutical agent be quite effective with the positive and negative that everybody knows. Thank you.
Dr. Eduardo, I share your views because we had a lot of patients who had similar kinds, small cysts near the macula, vision going down, dropping down, and those patients really do well with aflibercept. The only issue I found with ranibizumab is sometimes when you give the injections, unfortunately I can't show you the images because the projection has stopped, but you'll realize that the OCT characteristics of these cysts changes. Normally when you look at the cyst, you see it as a clear content, There's hardly any, it's basically a hyporeflective cyst. But I have had patients, when you look at the OCTs, you start treating them, you realize the cysts sort of solidify. Is it because of exudation? Is it because of extra amount of proteinaceous material coming in? But at the other end, we need to understand that anti-VEGF works by the principle of reduction in leakage. Why should these patients have cysts with chain characters from hyporeflective to become more hyperreflective cysts? That's the first question. The second question to note is, both Lucentis or ranibizumab and Eylea work very well. So in my practice, what I would do is, yes, of course, you have characteristic features which you want to be treated with either of these medications, but I would give the option to the patient. The first thing what patients would ask me is, doctor, how long have you been using this medication and what's your experience? Now for us, as all of us in Dubai, we have the newer medication only for about 6 to 8 months. So the moment you share that experience, a lot of those patients would want to continue on ranibizumab before, because they know for sure this medicine has been there for some time. They think there is a sort of view of theirs that this could be an experimental medication. Though we have tried to explain to them, yes, this has been in the market and people have used it for over 2 years, they still tend to more be inclined towards ranibizumab. The moment you have patients who don't respond to ranibizumab, at that point of time when you offer them aflibercept, they're more in the sort of, they're more tuned to taking it, because they realize that the visions are not doing well.
Can I Rao, sorry, just to answer, because we've been know each other for 4 years, and we are in the same line. I'm very happy that you raised the first question, because I'm thinking a lot about this, actually, about the fact that Rao said that when we see an improvement, is the cyst become to be much more opaque, hyper-reflective on OCT. My idea, that is just a personal idea that can be completely wrong or completely right, is that the fluid is reduced in production and there is a much more absorption. What is left is the solid part.
Yeah, the lipoproteinaceous material.
Exactly. So it may take a while to get rid of it, but it means to change from black to whitish that the treatment is acting very well. So you need maybe wait a little bit longer to make it disappear, but you are on the right track. This is my thinking.
But you also realize those cysts are at the inner layer. So generally, if you look at hard exudates, they would be slightly deeper. So if you expect those to be lipoproteinaceous material, then ideally they have to be in the deeper layers of the retina. You don't find them in the superficial. I can share with you some OCT images where the cysts actually are on the surface, the inner retina, and they start changing the characteristics. It's very difficult for, yes, we can see it, but unfortunately the technology has advanced so much, but our knowledge hasn't followed up. So we don't know what that material is unless you get some sample, which is very difficult in these patients.
I totally agree. According to me, is protein material that is not coagulated, so it's not a weight to go down, and they circulate inside. So it means that there is an active process in production and reabsorption that the OCT can show us, because the density is quite enough. But because they don't get together, they don't precipitate
down. Yes.
I would like to comment on the perception of your patients that this is a drug which has recently been introduced, and I would like to see it this way, that our experience with Eylea is fairly recent. As they say, your patient scored 6 to 8 weeks or whatever. But as your cohort size builds up over months, maybe you have a scenario where you have treatment failure with Eylea and you put them back on ranibizumab and they may perform. Also, there can be an issue of tachyphylaxis with repeated dose of any drug. It could be either. So what would you say on that comment?
Tachyphylaxis is a known thing with medication. In fact, one of the reasons why and ranibizumab is presumably stopped working is tachyphylaxis. But if you look at our patients, none of them responded to ranibizumab, and they were getting worse on ranibizumab. Some of them remain stable. So in tachyphylaxis, by definition, it would be patients who respond initially and then they get worse, or probably the drug doesn't work. Here, it's right from the beginning. So I wouldn't consider tachyphylaxis in these patients, first point. The second point is my cohort is pretty much very small. I have till now about 10 to 12 patients, which is a very small number in compared to the 800 patients which were treated in the trials. But over a period of time, yes, I would expect that some of the patients may not respond to aflibercept, and then we might have to turn them to ranibizumab, which is known. Any anti-VEGF, it's a standard, it's known as an anti-VEGF switch. One anti-VEGF works, may not work, then you shift it to the other one. Like you switch between ranibizumab, bevacizumab, and aflibercept. Unfortunately, we don't have bevacizumab here. But among the two, you would want to have patients who would switch as and when necessary. And if both don't work, then you have the other options, the other medications as well. But we need to be aware that this is a chronic medication, this is a chronic disease. Patients would require long-term treatment. They would require about 8 to 9 injections in the first year, maybe 2 to 3 in the second year, and the third year is just 1 injection. But the patients have to be aware that they have to come for follow-ups. That's the problem here. Patients would drop off after a period of about 6 to 8 months, and they would just be lost to follow-up. Thank you.